American flag. Follow me. I pledge allegiance to the flag of the United States of America and to the republic for which it stands,
one nation, under God, indivisible, with liberty and justice.
Thank you, Jessica. Okay. Before we begin the meeting, we have two new members of the commission. We have Jim and Rick. Jim and Rick, you just want to give us the 30-second background. How you got here, who you are. Jim.
Okay. Jim Hammersley, grew up here. Family's been here since the 50s. Grew up here, graduated high school, left for 35 years. Begged my wife to retire here. So I kind of retired here. Ran for District 1 supervisor against Travis. He beat me by 250 votes. He asked me, what are you doing, Jim? Would you like to, he told me about this position, and I said, sure. He goes, throw your application in, and here I am.
Great. Welcome. Rick.
Hi, I'm Rick Hernandez. I reside in Bullhead City, Arizona. I currently work for Mohave Electric Cooperative as Human Resource Manager there. My HR background is somewhere around 20-something years. I'm originally from New Mexico, but I have lived here in Bullhead City for 21 years. So. And I'm very excited to be here. Rich asked me and talked to me about this position. I'm very interested. I thought it'd be something really great for the community. So I'm very glad to be here. Thank you.
So now I have my own resource just a mere 2 miles away. But I can ask a question. That's nothing on Joanne and the team, he does do this type of work for a very large employer here, which is great. Okay. I'm going to have call to public. Is there anybody that wishes to address the Employee Benefit Trust Board? Okay, hearing none, I'll go ahead and close the call to public. The first item we have on the agenda is regarding the approval of the March 20th, 2025 minutes. Do I have a motion from the floor? And yes, you two may vote on this, by the way. Even though you weren't in the meeting. Do I have a motion to approve the minutes, please?
I'll make a motion to approve the minutes.
I'll second.
Okay, we have a first and a second to approve the minutes of March 20th, 2025. All in favor, say aye.
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 Any opposed? Okay, hearing none. That's best. And I forgot, we need to introduce who is joining us through Zoom. So if we can go real fast. Yes, holding up your hand, if you would kindly introduce yourself.
Yes, I'm Susie Perel Duranzo. I'm in Michigan right now, but I will be able to join you in the meeting.
Susie, we're glad you're here. Thank you for joining us.
Thank you.
Who else do we
Thank
have?
you.
It looks like Sherry. I can really read it from here. Sherry, are you there?
I am here, and that's Sherry Ballou, like the Jungle Book. I am director of PBM audits over at Gallagher, and I will be going over the report for the pharmacy claims audit that we perform for you, if that's what you would like me to do.
I'm sure we will. Kim, can you introduce yourself, please?
Good morning. I'm Kim Heaney, Pharmacy Account Executive with Gallagher. So I'll be on the call with Sherry and Meredith from our audit team.
Okay, and then finally, Meredith, if you're on, can you introduce yourself?
Hello, yes, I'm Meredith Dubuisson, also with the pharmacy team, and I will be supporting Sherry and Kim. Okay,
thank you all for joining us. Our next item on the agenda is the discussion, consideration, and possible action regarding Navitas Prescription Benefit Manager Audit. Which member of staff would like to take this one?
I will introduce it, then I will turn it over to our audit folks to add any commentary concerning the results of the audit. So attached are the results of the Pharmacy Benefit Manager Audit. This is an audit of the 23-24 plan year. As part of the process we went through several years ago with an RFP, the RFP in that was included annual audits to make sure that the PBM is fulfilling their contractual obligations on several levels, rebates, discounts, and other contractual terms. And so with that, I will turn it over to my team to go into more detail about the results of their findings. So
Okay,
Kim,
team, who would like to step up?
Kim or Sherry, who wants to take it from there?
I'm happy to step in, Jim. Hang on one second. I'm trying to pull up the report. Okay. I think that's it. Can everyone see that?
We can.
Okay, so I'll give a very general, high-level overview, and if there's anything that you want more detail in, I'm happy to go through all of the scope items one by one. Basically, what we did was we did an audit of your July 2023 to June of 2024 benefit period. There was a total of 15,824 claims that were paid, representing amount of almost $3 million, 2.990586. We reviewed pricing, rebates, benefit design, and utilization management accuracy. And overall, you can see in the table here that we had an estimated error of $263, which is actually very good news, fabulous news for Mohave, because it represents that Navitus is doing a good job managing your pharmacy benefit. You really don't want us finding major issues. So those errors involved minor issues with excluded products and with quantity limits. The Navitus has agreed to those errors, and we're doing some system adjustments and coding updates so that those don't occur again. Otherwise than that, your financial guarantees, their performance was actually a surplus, which is also exactly what you want. I can give you a little picture here, what it looks like. Sorry, did somebody want to say something?
No, go ahead.
Okay. What we do for this, because these are the big pieces of the audit, is that we will independently do our own reconciliation of your claims. We pull the terms that are in your agreement, and the important ones that we use in our analysis are present in the report. And then we basically will then apply the guaranteed discount rates and dispensing fees that you have and do a comparison of what our results were versus what Navitus came up with. And there are three major areas that they look at, which is the retail channel, the mail order, and specialty. They had an overall, as I said, surplus. They reconcile by channel here, which means that even though you're seeing individual channels here having a negative amount, overall, because there was such a surplus or overperformance in this particular category, it wound up with an end result of an overperformance in that. And again, that is what you want, because there are times when there are shortfalls, which means that you overpaid, and then the PBM has to pay you back at the end of the year. But that's money that should have been in your pocket in the first place. So that did not happen with Mohave. So that is fabulous. For mail order and specialty, we put an asterisk here because the guarantee is not applicable per the terms of the agreement unless there's a minimum of 1,000 claims. But we included, we didn't do the assessment here because it's not applicable, but we wanted to give you an idea of how these channels performed. And again, even there, even though it's not a guarantee, both of those channels wind up having an overperformance anyway. So that was great. another one that I'd like to go through if there's no questions.
Now, continue.
Okay, is the rebate guarantees. That's also a big area. Again, we do our independent review based on the contract terms that you have. We will separate out by the channels what the minimum guarantee is per claim. These are brand claims. And again, there was a restriction that the guarantee would only apply if there was a minimum of 150 claims quarterly. So for these 3 channels, there is no minimum guarantee that's applicable. The only one that there was retail 30. Our calculation was 261,000 that was owed. Their guarantee was 248. And the amount of rebates that were collected from the manufacturers was 1,093,000. And because this amount here is higher than the guarantee, this is the amount that they owe you. So even though we had a little bit of a variance here, like ours was, what's that, about $13,000 higher, it doesn't matter because the amount that they collected from the manufacturers is what they owe you, and that's what they paid off of. There's a little excess here, and that's probably from some rebates trickling in, from another invoice period.
Okay, I have a
So,
question.
yep.
So we have 2 new members of our board. Could you give us the 45-second overview of rebates? Somewhere, just, I think I understand it, but our 2 new board members may not be up to speed. Why we're getting rebates from manufacturers and where does that money go to? I think I know.
Okay.
Yeah.
Yeah, well I'm sorry, did someone else want to take that?
No, go ahead.
Oh, okay. It basically all has to do with your formulary, which means what drugs are covered for your plan for your members. And there's a lot of negotiation that goes on, and because brand name companies, they want their products on their formulary. In order to be placed on their formulary, what they do is we'll say, we'll give you money back. So they get the market share, their products will be filled, but because they're typically more expensive than other alternatives or generics, the fact that they're on your formulary makes them, at the end of the day, cheaper than what the generic or other alternatives would have been. So when they negotiate that, it's supposed to be better overall for your pricing. So they decide, they take a look usually on what your utilization is, and that's how the rates per claim are negotiated. That's what the minimum guarantee is. And then what happens is they'll submit to the manufacturers the actual claims that were filled. The manufacturer will say, thank you very much for filling our products. Here's the money that we're giving back to you. That's the incurred rebates or the rebates collected. And then that comparison is done. So as you see here, what you actually got from the manufacturer was higher than the negotiated minimum rates. Did that make sense?
Made sense to me, gentlemen.
Yes.
Yes, apparently it makes sense. I just had a quick question for Luke. Where does this money end up at?
Yeah.
The rebate money?
Yeah.
That comes into the county and ends up in the trust balance.
Okay, so, perfect. Let's continue.
Okay. So just another quick overview here. You have a pass-through arrangement with Navitus, which means that they're not going to take any extra money. Whatever they pay the pharmacy is charging, whatever they pay the pharmacy is what they are going to be billing you for. So we want to make sure that they didn't take some spread on that. So we selected 15 samples and just said, send us the remittance. And we compared the price that they paid the pharmacy to what they billed you. And we confirmed that those amounts matched.
Perfect.
So for the average whole price verification, the whole thing behind the pricing in the discounts, the baseline is the AWP price. So we need to verify that the starting point is correct to begin with. And we did do that. We have our own subscription to Medispan, and we will, on the NDC level, claim each and every claim. We will compare the AWP that they apply to the claim against the AWP that we see on Medispan that's effective for that date. And you can see here that we matched 99.9%, which is very acceptable. There are some very slight variances that are expected because of, some people update the files monthly, some weekly, that kind of thing. So that was acceptable. Plan payment formula is just to make sure, are they doing the math right? After they figure out what the ingredient cost is and what the copay charge to the member was, or any other payer amounts coming in, did they do the math right to charge you the correct amount? And you can see here that we matched 99.9% on that. There was a $1,300 variance that we saw, that technically you were overcharged for because we didn't see those amounts. But those were mainly accounted for vaccines, where it is industry standard to have a $15 to $20 vaccine administration fee for that. And so, you had a lot more vaccine claims that I think had that fee incorporated into the ingredient cost, and these didn't. But again, it's a very insignificant amount based on the $3 million of spend. So we thought that was fine.
Okay.
We check for duplicate claims. We want to make sure you're not getting double charged, and we verify that did not happen. Additional pricing terms is that you're guaranteed the lowest price of anything that's possible, whether it's the maximum allowable cost if it's a generic, or whether it's the AWP discount, or whether it's what the pharmacy would usually charge for the medication. So we looked at all of those three fields to make sure that you always got the lowest amount charged, and we confirmed that you did.
Okay.
You also have some base administrative fees for the processing of your pharmacy claims. For Mohave, there is a per member per month fee. In this time period, July through November, it was $2.28 per person, and then it was increased to $4.73 starting in December. So we asked you guys for your enrollment numbers, and we compared that against to what Mohave had, and then applied the appropriate admin fee based on the time. And you can see here that they basically matched up. So that was that scope area passed.
Okay.
Moving on to benefit design, which is deductibles, copays, and maximum out of pocket. We took a look at your plan design documents to see what your parameters were. We did see that your PPO plan had a $0 deductible, and your high deductible plan was $3,000, $6,000. So what we do is we'll take a look at if there's a deductible field in the data, we'll add that up to make sure that these amounts were not exceeded. The other thing we'll do is we'll independently accumulate everything based on the pharmacy claims that we have. Your plan is integrated with medical, though, so we don't have the medical claim information. So what we'll do is we'll tag people who we think are in the deductible phase. And if they were getting coverage copays, we ask for documentation that they met the deductible with medical. Or if we see that the member should have been in the coverage phase and they're paying full cost of the drug, we will ask for documentation that shows that they were still indeed in their deductible phase. And we sent actually just a sample of 3 potential exceptions that popped up, and they were able to give us that documentation that with the medical claims that the accumulators were calculated correctly.
Okay.
Oh, I also forgot where there's a 0 deductible, we make sure that none was charged, and that was the case. And very similar for the maximum out of pocket, the same, we do our own accumulators and send sampling similar to that. So if we have them as having met their maximum out of pocket and we're seeing them paying copays, we'll send a sample for that. Conversely, if we think that they have met their maximum out of pocket and, oh, did I back that up? Sorry. If they've met the out of pocket and they're paying copays, or they're paying 0 and we don't think that they've met their out of pocket yet, and it's not like an ACA drug that's eligible for 0. So in this case, we sent 29 possible exceptions, and they were able to provide that medical documentation, which put the members in the correct phase. Everything's great. And then for copays, this would be your general when they're not in any deductible or MOOP, the baseline standard benefit, that's applied. And we saw 15, we sent a sample of 15 potential discrepancies, and we took a look at the documentation, and most of the time it's, again, because of the medical accumulators that will put them in the proper copay charged. For excluded products, we'll take a look at the benefit design again and then run a test against the claims to see if there were any claims that were paid without a prior authorization. We did send 3 potential discrepancies. Navitus had confirmed error on 1. This was where the product, where it was only the prescription drug was covered, but not the over-the-counter. So they agreed in one case, the over-the-counter product paid when it should not have. So that's where they're going to be looking at that. We estimated that we only found 2 claims for the year. So it's not a lot of money, but just shows you we're honing in on everything. For prior authorization, did a great job there. There was just 1 potential exception that we sent in, and they must have provided some documentation that either had a member level prior authorization, or perhaps the formulary was not effective on that kind of date. It doesn't specify here, but we did receive some confirming documentation. For quantity limits, we sent a total of 3 potential discrepancies. Navitus did agree to 1. They admitted that the claim processed and there was a issue in the claims system, which has since been corrected. And we estimated that was $207 for the excess quantity paid for that. And then finally, step therapy. We'll take a look at the drugs that require step therapy and any of those drugs that don't have a prior authorization, or that we can see a qualifying claim in the data that we have. We'll send those in. We sent 2 samples, and they were able to provide documentation that the member had the prerequisite therapy, or had been on the step 2 drug for a period of time before this audit period. So I know I spoke very quickly there. So if anybody has any questions, happy to address.
Open this up. We will not have a quiz on everything.
That's what you
Mr.
say.
Chairman.
I would have moved you along a lot faster. Okay, that's just my style, but that's all right. I get it. So we're going to open it up to questions. Does any board members have questions about the PBM?
Susie raised her hand. She has a question.
Susie, take it away.
Yes. I have a question going back to the rebate and the pass-through payment. When they build the trust for whatever was used, do they subtract actually the rebate, or that's a different payment? The rebate is a different payment altogether to the trust. Do they offset the difference of the rebate?
Which one of you which side of the table would like to answer that question?
I mean, we end up getting a rebate payment to the county, so I'm assuming it's.
Susie, did you hear that answer?
Yeah.
Yes. So basically, the pass-through payment, we pay the provider everything they expended, and then the provider gives us a rebate to the trust. Is that the way it works?
Yes.
That's correct, Susie.
Okay. All right. Thank you.
Mr. Chairman?
Yes.
I have a question. So do you actually go through all of the claims? Just for instance, on the excluded product and the quantity limits, there's 5 of those with 3 submitted. So you go through all the claims and you only have 5 possible errors? Is that my understanding? And if so, then you narrow it down to 3 that you submitted and there was a 33% error rate. Is that correct?
That's correct. We do look at 100% of the claims. So there were only 5 where the quantity limit was exceeded and did not have a prior authorization. If it had a prior authorization, we clear it.
Does that answer your question?
Yeah, why is that percentage so high on those particular assessments?
I'm sorry, can you repeat?
Why would it be such a high discrepancy, 33% error rate on their part in those 2 categories?
Well, you have to put in context the number of claims, right? You had 15,000 something claims, and there were only 5 that were potential errors, and comprising of 3 different categories, and there was only 1 that was found to be in error. So percentage-wise, it's high because of the number of error claims, potential error claims, but overall, I mean, that's a very good error rate. I mean, it's not perfect, but in the big picture, it's small.
And one other question that I have on the formulary, I know in the past we've run into at least one case, probably more, where something wasn't covered under the formulary, but a different product that would have been cheaper would have been. Is there a way for our members to know that and be able to get something different in the formulary so that they can get a cheaper prescription that maybe is not on the formulary?
Well, how the formulary works and how it works at the pharmacy is the pharmacy will code what your formulary is. So if a member comes to the pharmacy with a prescription for something that's not covered, the pharmacist will get a message that says not covered, use formulary alternative. So, or get a prior authorization. So at that point, the pharmacist will probably call the doctor to see if there's something else that they can prescribe that is on the formulary, or they'll apply for that prior authorization to get that drug covered.
And how does our member know to ask for that prior authorization for something that's excluded in the formulary?
They would know when they show up to the pharmacy and the claim is rejected, or depending on how the system is set up. I mean, some doctors' offices are set up to know what the formulary is so that they can pick what is something that is on formulary in the first place. But I'm thinking that that's not the case with Navitus. It's not impossible that happens, but I think more likely in your case, the doctor would prescribe what he wants, and then they get the message once they try to fill it at the pharmacy.
Other questions?
No.
Gentlemen, any questions for Sherry? Okay, I am looking for a motion to approve the audit.
I think they did a great job on the audit, and I make a motion to approve the prescription benefit manager.
Second.
Okay.
Second.
Thank you.
We have a motion and a second to approve the PBM audit as presented. I'll take a vote. All in favor, say aye.
Aye.
Opposed? Okay, the ayes have it. The motion passes. Let's go to the next item, which is a consideration of an RFP. Who would like to explain this?
I will go ahead and kick it off, and then again, if there are any questions on the scope of the project, anything like that, we have our pharmacy subject matter experts to address any questions. But essentially, PBM contracts are negotiated in 3-year chunks. We did this a few years ago. We're in the last year of Navitus's contract, so we're in the 3rd year. So typically, kind of as a course of due diligence, when the contract is up, we propose on if we should enter the project again and do another RFP. The PBM market is very dynamic. Just a historical perspective, when we did the PBM RFP last time, Navitus was the incumbent, but they went through the RFP process. As a result, they kept the business, but the RFP process resulted in over $2 million of savings over the negotiated 3-year contract that they ended up going with, which is far greater than what they would have done if just accepting their renewal offer. So the pressure of the RFP does have some potential positive results. I can't say that you're going to get these types of results every time, but the market pressure and the fact that the PBM market is very dynamic with the way contracts are changing, PBMs entering, different PBMs getting more aggressive, it would be a good exercise to see what the market has to offer Mohave County with respect to PBM services. It doesn't always mean that you're going to make a change, but it gives you the data to make the decision for the best for your members and the plan.
What's the renewal option if no RFP is issued?
We would review their renewal contract, compare it to what is currently in place, and kind of give you an estimated either savings or increase based on their renewal contractual terms.
Okay. So by going through the RFP process, assuming Navitus comes back and replies to it, if that RFP comes in higher than the renewal option, which I think is 3% increase over the year, can we still fall back on the 3% increase? As unlikely as that is to happen. Does that make sense?
Yeah, I believe that. I mean, that would probably be up to them to be able to honor those contractual terms, or
Okay.
without speaking for what they're willing to do. They may say, well, you went through the RFP process, and as a result, this is our offer.
That's my question. Yes, sir.
Mr. Chairman, thank you. Given the market pressure that you spoke of, is there a chance that the RFP would produce higher values, higher cost than what we currently have? Intuitively, I'm not seeing that and understanding that there's no cost to the county for the RFP process, and we have plenty of time to go through it. And the nature of the beast is that competitive processes produce better outcome. It seems to me it would be a slam dunk to go in that direction. Do you disagree in any way, shape, or form with that summary?
No, speaking anecdotally, the past several PBM RFPs that I've been involved with have all resulted in savings over the current contract.
So she's 3% each year.
Okay, so in the interest of time, do we need to go over the supporting material, which is almost 40 pages long behind this item?
No, that is more of there for an encyclopedia for you to be able to use for reference if you have questions, not as a presentation. So, yeah, I apologize for all the material. A lot of it is reference, but I do want to clarify, as Sam mentioned, that there is no cost to the county directly for the PBM RFP. There is a cost for the pharmacy practice to do it, but the way that it's presented and was presented in the past is that the winning PBM includes that in their pricing and then amortizes those fees because we build in the cost of audits. If you were to move to a new PBM, there'd be also an additional audit, which would be a post-implementation audit to make sure that the implementation went correctly. So those are all embedded into their pricing. So to even build on your point, their overall pricing, which last time was $2 million over the course of 3 years, that also included the fees. So there was savings even though there were fees. So from a net perspective, there's not a net cost to the county, but I just wanted to make sure that on the spirit of transparency, that the scope of the project does include fees payable to Gallagher, but via the contract with whoever you choose to bind coverage with.
Okay, so the RFP is in fact created and issued by Gallagher on our behalf.
Yes.
Okay, so the county doesn't worry about Terra gang down there. Okay, questions?
Chairman, the last RFP, how many providers or service providers did actually?
I'd have to go back and look to confirm, but I believe 5 started, and then 3 ended up being the finalists. And then there was 2 rounds of best and final where those 3 kind of sharpened their pencil, if you will.
And you don't see a problem with that many, again, if we could go ahead with the RFP, and there will be competition out there.
Yes, and we've kind of found 5 is a pretty good number. That provides a pretty good, anything beyond that, you're getting a lot of contractual redundancies. So then you're really getting into narrowing the field. So we're using the expertise on the region, the size, the sector of the group to find, that 5 or 6 PBMs that are going to be the best fit, and then work from there. And it is proven to show competitive results.
Susie, did you have a question? I couldn't tell.
No.
Any other questions? Joy?
Then we'll move to approve the PBM RFP to be facilitated and managed through Gallagher's PBM specialty practice.
That was a motion. I need a second.
Second.
Okay, we have a motion and a second to approve the PBM RFP to be facilitated and managed through Gallagher's PBM specialty practice. All in favor, say aye.
Aye.
Okay, we have a unanimous vote in favor. Let's go to our next item. Check out this one right. It's an overview of the Benefit Employee Trust offering. Who would like to take this?
I'll take this. And this again was a recommendation from staff to do a very brief benefit overview for the new folks. So as we're talking and going through all this detail, I think it probably adds a little bit of context that what the benefit offerings that the county provides to their employees. So I'll give you just a few minutes overview, and then if we have any questions, we can go deeper. But I'll just start. The county offers its current benefit eligible employees 2 medical plans, an EPO plan and a high deductible plan that's been consistent for several years, offering choice. Here's kind of a very high level list of what the benefits are. I won't go through each one, but the EPO versus the high deductible health plan, along with the high deductible health plan, is a qualified health savings account. The medical network is Blue Cross in Arizona, and then if you venture out of Arizona, it has Aetna as kind of the national wrap network. In addition to medical and RX, 2 dental plans, a high and a low plan. So again, maintaining the spirit of choice, folks can choose the benefit level that best fits them. The vision coverage the way it's structured, you have access to either the IMED or VSP network, depending where somebody likes to go. If they like to go to, Walmart, they may choose one network. If they like to go to Costco, they'll choose another. So pretty much covers access from that respect. Basic paid life is $50,000 with an option to purchase additional supplement. Short-term disability is 60% of earnings, maximum weekly benefit of $2,200. And then in addition to those kind of fixed programs, the county offers quite a robust wellness program, including the following on-site screenings: health risk assessment, skin cancer, blood draw, cardio and organ, mammograms, and flu vaccinations. It also has some targeted well-being programs through Digby Health, along with virtual physical therapy through Hinge Health. So pretty robust wellness package that is designed to address people in person, and then also address access issues for folks that may have to need virtual physical therapy and you can't always get in. So trying to, rural areas are always a challenge. So we want to make sure that we're trying to do the best we can with options that increase access. Also has employee assistance program through CureLink, and then a couple employer-sponsored voluntary benefit programs, a accident plan, a critical illness, and a hospital indemnity. So that kind of rounds, and those are voluntary. So anybody, you don't even have to sign up for the medical plan. That you can waive those coverages but still purchase the voluntary benefits if you choose to. So that kind of rounds out. I know it's very quick, but that kind of rounds out the benefit package.
We like quick.
What's that?
I said we like.
I had a sense you did, so I wanted to meet your expectations.
No, but gentlemen, that was a really brief overview.
Yeah.
He's going to get into the wellness portion on the next tab anyway. Good. So there's no action needed on tab 6. Let's move to tab 7, which is an overview of our wellness program. And who's going to handle this?
That's me. I wasn't at the last few quarterly meetings, so I didn't have the opportunity to meet some of you in person. My name's Tori. I'm the wellness consultant for the group.
Welcome.
So, thank you. It's nice to meet you, see some new faces. So I'm going to provide an overview of the wellness program. There's been some exciting changes that have taken place in the wellness program this calendar year so far, the biggest one being the implementation of Digby Health. This launched July 1, and this is a really amazing, holistic, just whole person program that is focused on really identifying the root causes of health issues. So every employee that signs up, a quick overview, receive a continuous glucose monitor, a gut microbiome test, and then a genetics test. And this testing and lab information is used to create a personalized care plan for them that is delivered to them through a dietitian, a health coach. So it really is taking the user's unique biology and physiology into account for every recommendation that's provided to them. The biggest part of the app is the nutrient density or meal scoring aspect of it. So users take a picture of their food and AI pulls out all the ingredients in their food and runs all the ingredients against all of their lab testing results. So it can say specifically to them, based off of this marker in this lab, you should switch from sour cream to Greek yogurt or whatever it may be. So it's really simple, sustainable choices that add up to bigger health outcomes in the long run. So I have included in the packet just some high-level overview of the engagement of the program. So since it launched July 1, there's now 153 users enrolled in the program, which is a pretty good turnout. We're excited to see it. I came also in July for a few in-person presentations and had the opportunity to talk to employees face-to-face because we know it's really hard to communicate this stuff via email to them. So it was great to be here in person and just get to talk to them and answer questions that they had about it. In the packet, the next bar graph, one of the things that Digby tracks and monitors, they have a big emphasis on gut health, is the IBS symptom severity that employees are reporting. IBS, irritable bowel syndrome, can be a really frustrating diagnosis for someone to receive because it's often given when they can't really figure out what's wrong. Symptoms can be really debilitating for people. More employees calling out sick, taking more medications, less productivity at work. So Digby is monitoring these symptoms, and you can see, I know it's kind of small on the screen, but in month 1, 18% of users were having daily severe symptoms. That dropped to 10%. In month 2, 55% were having really mild to no symptoms, and that increased to 70% in month 2. So that's just after really like 30 days of utilizing the program, which again translates to better energy, more productivity, less medications, less sick days. So really exciting to see that. I'm going to read.
Victoria,
Yeah, go ahead.
on that first chart, this says program launched July 1st. How do we have June?
Yes, so it technically opened up like 10 days prior to July 1 because of some of the marketing that they were doing for the July 1 webinar. Good question. So I have 2 quick testimonials from users that I want to read because they're really amazing. One member was only 23 days into the program, had lost 11 pounds in 23 days, and said, digestion issues have improved 100%. Sleeping well, still need a little more energy. Following the food guide and many of the recipes has made it so much better. Second one, this one makes me laugh a little bit. Before Digby, I wasn't an early bird or a night owl. I was a permanently exhausted pigeon. My weight never moved. I battled constant bloating to the point where I looked pregnant, and I had no energy to live, only survive. Since starting Digby, I've lost 10 pounds, my bloat is mostly gone, and I'm finally learning what my body actually needs thanks to my gut health insights. Most importantly, I feel myself feeling more alive, energetic, and hopeful. Digby hasn't just helped me lose weight, it's given me my life back, and for that I am so grateful. So those are really powerful testimonials after only a few months into the program. I know some of you are new. We did not get any kind of feedback like this with the programs that were previously in place. So to only be, a few months into the launch of this and already be getting this kind of feedback is really hopeful and really exciting. I mentioned that users take a picture of their meals and Digby essentially rates the meals. This kind of creates a little competition, I have heard, amongst people. They want a better score. They want that kind of like green light for their meals. Then these scores rose from 9.63 in month 1 to 11.2, which is a 16% jump in 1 month. Digby has noticed trends of scores over 11 being associated with better weight management, better gut health, better metabolic health overall. So it seems kind of like a silly number to track, just like scoring your meals. But what this shows us is that on a daily basis, employees are changing their habits. They're changing what they do with every meal. So that's really what you want to see, is sustainable change through their daily habits. One of the things that we'll be focusing on with the marketing moving forward is providing more marketing towards men. It's very common to mostly just see women engaged in programs like these, no matter what the program is. 80% of enrollees are women and 20% are men. So Digby will be providing more targeted marketing efforts towards men, as well as dependents too, because we want family members to take advantage of this. We want spouses to be doing this with each other. So when you go home, it's not an isolated effort to make your meal. You can make a meal for you and your partner that are working towards the same goals.
Yeah, we'll return to marketing at the end of your presentation.
Sure. All right, moving on to Hinge Health. John did briefly touch on this, but this is the virtual physical therapy option that's available to employees. So again, like John said, sometimes this is difficult in more rural areas where employees don't have as many in-person offices to go to, or there's an office, but there's a wait list, 6 months long. So this allows them to do physical therapy from their home, from wherever they're on vacation, whatever it may be. They set up their phone, their iPad, and it takes them through a session with a physical therapist. So it's a really cool program. 55% of employees have experienced a reduction in anxiety, 44% a reduction in depression. In 1 year, members complete an average of 44 treatment sessions. And a new addition to the program is their women's pelvic floor program, and 18% of users have taken part in this program as well. Quick little snippet from a user. I'm amazed at how much Hinge Health has changed for me already. Less fear, more confidence, more understanding of the pain and what to do. It's been a relief.
Can I add something to that?
Yeah.
Hinge Health, when they started, I don't know how many years ago that we started it, but within the last year or two, you can now do 3 body parts. Before it was just 1. And that's a huge thing. And I don't know that a lot of employees realize that. They went on because they had a back issue or something, and now their back issue is fine, but now their knees are out or whatever. And I don't think they realize, oh, number 1, I could go back for something different. And number 2, now I can do 3 body parts.
Yeah, absolutely. And another upgrade that they've made is that users used to have to literally attach sensors to their body so that the camera could pick up how they were moving. And now they don't have to use any sensors. That was feedback that I got a lot. It was like, oh, I forgot my sensors, or I need to charge them, they're always dead, just these little barriers that keep people from engaging in the program regularly. So that's an additional upgrade that they've utilized or that they've made. So yeah, I feel you about Hinge Health. Whenever I come to the health fairs here, people are like, that's a really cool program that's available to me. I'm like, yes, it's here. All right. Like I said, I wasn't at the last meeting in person, but it was relayed to me that, wellness incentives was a discussion that you wanted to have and just talk about some ideas. And I'm happy to share what, some of my other groups do and utilize for this. I know that sometimes with wellness incentives, it's never great to think you have to bribe someone to take part in their health, that you want them to be an active participant, but sometimes people need a nudge in the right direction, and unfortunately, like it or not, wellness incentives are what get people to engage in programs, to get them to come to screenings, to sign up for programs, to regularly take part in these things more often. I think sometimes we think of wellness incentives just as prizes to be given away, but there's a lot of different avenues you can take for incentives. I listed some of them here. Premium reductions, days off, mental health days, volunteer opportunities, offering PTO for employees to volunteer in the community, employee recognition programs, on-site fitness classes, and again, kind of raffles and prizes for attending on-site screenings. We've also this fiscal year rather, started creating with the removal of the Navigate program, started offering quarterly wellness activities and focuses to the employees. So, feedback that we previously received was, I don't like apps as much. They're confusing for me. I don't want to have to maybe log a walk on an app for points. And so we're really kind of shifting to try to meet more employees at a kind of an organic community level where, the activity is we're, doing a hydration challenge for the month of September. Here's a calendar you can print out and hang up on your desk and talk to your, coworkers about it, whatever it may be. So we are providing more structured activities on a quarterly and monthly basis as well, to try and just foster more of a culture of wellness that is not solely focused on an app. So with the addition of Amanda Kalamura in HR, she's really been kind of spearheading the communications about those things to employees. So I know she's really been working hard on a daily basis to kind of get the word out about some of these changes that have taken place, because I can only do so much from my computer behind the screen. So we really need people on site on a daily basis in departments all over the county talking about these things on a daily basis. That's what makes it successful. So yeah, happy to answer any questions, talk about marketing.
This is easily my favorite tab in the entire binder.
Great. Mine too.
Far more enjoyable to read than some of the upcoming tabs. Can we demonstrate a correlation between wellness programs and reduction in claims?
At this specific location or just in general?
Let's
or
go to general first.
Yes, in general, absolutely.
So I'm assuming there's some information that would break down the reduction of these claims. Some are small claims, some are big claims, some could be life-threatening claims.
Mhm.
And I assume that would involve not just doctors, but prescriptions,
Correct.
therapy, all this kind of stuff. Okay, so there is a correlation between the two.
Yes, and that's exactly the type of information that I look at when I monitor the programs that are in place. That was the exact reason I proposed getting rid of Livongo and putting Digby in place instead. Livongo had been in place for, I believe, 5 years, and there was no reduction in medical claims. There was an increase in medical claims, which is the exact opposite of what you want to see when you have a wellness program in place.
Okay.
That's 100% the purpose of them, is to lower.
Okay, so
medical
you're
claims.
happy with the enrollment number.
Yes.
I'm not. I think it should
I mean,
be
it could be higher, for sure.
yes,
could be
I
higher.
would like to
Yes.
see it go higher.
Yes.
And do we have any correlation yet between Digby and any claim activity for this account?
It's too early to say.
When will it not be too early?
1 year, probably.
Okay, it's fair.
Mhm.
I think your incentives, there were two that I really enjoyed. A reduction in premiums and simply paying people to get on this if it'll reduce my claims.
Mhm.
So I know this opinion may not be shared by my fellow board members, okay, but I absolutely would I would encourage us as a board staff to come up with a proposal to get more people on Digby. Period. That's it. Come up with an incentive, pay them. You okay with that, manager Elters? I see the grin.
Just say no.
It depends on the amount and how we say it.
Of course.
But,
So we have staff.
yeah, I went through the list as well, and I think reasonable approach has merit, in all honesty, and I'd love to see a proposal on how, not only what the proposal is, how we would integrate it and afford it, and then certainly monitor the outcome, see if it's producing the intended results.
Yeah, if I gave out $100,000 to the employees of the county and my claims went down by $200,000, I see a real fast ROI. Okay, very quickly. Plus I see healthier, happier employees.
Yes.
Okay, which is kind of critical.
Yeah.
Yes, sir.
Yeah, we have 130. What do you usually see the percentage overall in this wellness program?
For
Based on-
engagement?
Yeah.
So it's actually kind of a depressing number, to be honest. Industry standard is 4 to 5%,
Okay.
which is not great. With some of my other groups that have implemented Digby, I'm seeing around 10 to 15% utilization.
And that equates to what in savings? What you measure?
Yeah,
If you-
you guys might be able to help me with that. It really depends so much on the group and what the
Yeah,
claims
they're-
look like.
But from a large data collection, we can get that number from Digby. What they're kind of seeing as a whole is probably a pretty good representation, because the more we slice it down into smaller data sets, the less credible it is.
Right.
But and I can't remember exactly what they proposed, but it does have a pretty substantial ROI on all of the employers that they work with, so which is an encouraging sign.
Yeah, and there's probably some intangible, soft benefits that you can't really measure.
Yeah.
And only the employees itself and the managers that supervise them
Right.
know if they're performing better and so on.
And methodology too, right?
Exactly.
Because you're obviously, an ROI is going to be doing some sort of predictive modeling based on an event that did not happen. So how do you say an event that did not happen had a certain cost associated with it compared to what actually happened? So you can kind of play with that number a little bit. So it depends on, how their methodology in determining ROI is kind of determined. But they seem to be, from the materials that we've looked at, they actually seem to be on a more conservative side, which is not always the case when you look at wellness ROI. So I do think we're going to see some positive change in claims.
I think Jim's question. Oh, go ahead.
Go ahead. And then piggyback on the cash bonus. giving the employee that stipend, how do you track that? Once they do get that, they'll say, oh, that's good, and they'll accept that as an additional, well, I deserve it.
Yeah.
But it would be good to track that. Are we giving them the benefits? And it's
Yeah, so I do have
How do you
another
measure?
group that does a premium reduction for their employees. And I will say that this group has probably the highest engagement numbers amongst all my clients with their wellness program. For their premium reduction, the employees are required to earn a certain amount of points throughout the year. And those points are directly tied to the on-site screenings, the quarterly wellness activities we do, and then like signing up for programs like Digby. And the points vary depending on what the activity is, but once they earn those amount of points, it's submitted to their HR, and then HR is going into their Ben admin system and marking if they qualify for that premium reduction or not. But it's a pretty effective program. People are really engaged with it. People, even if it's only $5-10 off a month, people love it. They really want to.
That's what I was going to mention too. Like a lot of times, people see something like that, and then you get a few people that start doing it, and then all of a sudden it becomes a little bit of a competition.
Yep.
And most people start getting competitive, like, oh, okay, and then but then you start seeing the results, and that's what you want to see, and that's always the beauty part of incentives. So it just got to start small, and then it'll grow from there. It goes from there.
Absolutely.
Yeah, I think the collateral impact of this is major to me. So we see a county workforce that, frankly, to me, very hardworking and frankly overworked. Okay, that probably could handle their level of work a little better if they were healthier, and they certainly wouldn't be covering for employees who go out on leave. I think we just had one in our assessor's office, or what? Guess who's covering? Come on down to Bullhead when one of the assessor's employees is out on an illness, somebody from up here. Okay, and it's, we don't measure those kind of impacts. And anything we can do to make a healthier workforce and a happier workforce, real high on my list.
Yeah.
Yes, sir.
Mr. Chairman, we often look for proposals that have the potential to change the culture, which is really hard to do. This has that potential.
I agree. I agree.
Sorry, I have a question. Going back to Digby, I know we're only a couple months in, but the chart is the number of enrolled members. How do you differentiate between, somebody that enrolls? What do you consider, and do you monitor different levels of engagement across that enrolled group?
Yes. Digby does track those things. We want to make sure that people are not just signing up for the program, but they're utilizing it. They're not just doing the labs and then dropping off. I wonder if I put it in here. I didn't include it in this one. I can certainly find it and report back, but I believe that the engagement with these numbers, the continued engagement, was around 90%. So the 90% of the people who have signed up are still utilizing it on a daily, weekly basis. It's based on, how often they're taking pictures of their food, they're interacting with their health coach, they're, tracking their steps, their sleep in the app, things along those lines. So engagement on a daily and weekly basis.
And do we know what that costs the trust on a per employee basis? I can't remember if we had numbers when it was proposed in March or not.
The cost per employee is $1,050 per year, and then that's billed quarterly.
Through a claim.
Through a claim, correct, yeah.
But that's only 2 months, right? We've only had this for 2 months for the employees, so.
Yes.
I mean, it takes 2 months for people to either really adhere to a program or say, never mind. Because, I mean, I'm looking at your Hinge Health, 44 treatments in a year. That's not too many. And we've only got, and this has been going on for several years, but it's amazing to me that more people haven't signed up for that. 44 treatments. I know I don't want to say this out loud because I don't know if you're still getting billed for me or not as a county employee when they sign up. But my treatment plan is 3 weeks or a week 3 times, the next week 2 times, the next week 3 times. So 44 treatments doesn't seem like very many. If my numbers are included in there, that puts everybody else way down. So the same with, I mean, I could take a picture of my food. Nobody want to see that, but I can take a picture of my food. But that doesn't mean that, I'm changing what I'm eating. I'm still just taking a picture and they're telling me, oh, you should use yogurt instead of that sour cream. But tomorrow I'm still using the sour cream. So how do we measure the effectiveness and how do we reward employees? Because we don't track an individual employee to say, oh, good, they obviously did change from that sour cream to yogurt, other than just took a picture of it consistently for 365 more days.
Mm-hmm. So are you asking how we monitor engagement within the program?
Yeah, if we're talking about rewarding employees, how do we track it enough to reward an employee?
We wouldn't be able to reward an employee for, taking pictures of their meals 5 times a day. We're not receiving like that level of, reporting from Digby. We're receiving the level of reporting, how many employees are enrolled in the program, how engaged are these employees enrolled in the program. A reward, incentives typically don't revolve around like the wellness programs that are in place, the wellness apps, I should say. Maybe there's a reward for signing up for the program, but you kind of even have to be careful there because not everyone's eligible for the program. Incentives typically revolve more so around participating in on-site screenings on a daily basis or on a monthly basis, whatever is available to them. So you can tie some stuff into the apps, but as far as encouraging people to sign up for the apps that are available to them, we so try to approach it more from, education and making the education come to them in a way, right? That's why we organized events for me to come on site in July and talk to employees about it. Maybe it's having a lunch and learn where employees get to step away from their desk for half an hour and you feed them coffee and fruit or something along those lines. Those are really the more tangible ways to get a hold of people for programs and apps that are available to them, but you can't necessarily reward someone for signing up for the app, if that makes sense. I'm not sure if I answered your question.
Piggybacking kind of what this gentleman said, I can see rewarding somebody who signs up, okay, my sugar count is way up and I need it to go down. Okay, so you got it down and you kept it down for 6 months. That's, or your weight or, whatever it is. But until there's a way to monitor it in those employees who are eligible, I'm kind of dense on how we're going to figure out how to do a premium reduction for individual employees who may or may not be even eligible for some of these programs.
The premium reductions.
I love the program. So.
The premium reductions are typically tied to on-site screenings, not
because those drive down the overall cost
yes.
of trust.
Yes.
Catch things early.
Yeah, they're preventative.
Less expensive.
Yeah, and that's
available to the population, and it's available to everyone.
And that's what you're trying to do is incent participation. Beyond that, it gets very slippery trying to reward outcome. There are so many factors that go into changing outcomes. Somebody may, at some point in that time, well, I think it's discriminatory to do an outcomes-based reward, but within that realm, comorbidities may pop up that make somebody's journey challenging or more challenging at any given. So basically what we want to do is provide every avenue possible to get them down to the river to drink the water, but they got to at some point that, drink themselves.
Well, how about if you just didn't reward outcomes? Okay, you just reward results, which is at a higher level. So I want to see my claims go down. I want to see my number of sick days go down. I want to see my amount of overtime go down. Okay, those to me are tangible results that I might be able to link to the programs.
Mm-hmm. I did years ago at a previous job. I worked on site at a facility. It was for Blue Cross Blue Shield, and one of how they tied something like that to their premium reductions was they did kind of a weight loss challenge. And so again, there was some exclusions here. Not everyone was applicable for a program like this, but if you fall within, you know, a certain BMI category, there was a program provided to them, Digby or, you know, something local, and they had X amount of time to get the BMI into XYZ category. And there were weigh-ins on site at the gym, maybe at the health department. I know other clients I have do stuff like this with their health department, but that directly translates again into some of those, you know, more outcomes that translate to, you know, less medications, less sick days, better energy, focus, things like that. So you can explore things like that, but it is kind of a slippery slope, like John said, sometimes with outcome-based rewards like that, but they do exist. There are ways to do them. They're just a little bit harder sometimes to present to your population.
Why don't we let our staff explore the outcomes? I mean, the different ideas.
I would like to say that mindful of our employment population, the number and the mix, and understanding there are some that are in less than perfect health than others. And we want to attract both. We want to attract the healthy ones to stay healthy and the ones that are well to get well or get better. And recognizing that some of these programs may take a good faith effort to start it and then to monitor after a year or two to see how it's impacting the claims. I think if there's a will, there is a way, and I think it's worth the risk for us to attempt something. So coming up with collectively coming up with something that balances out what we can afford with the incentive for people to sign up. And I will go. It's my personal belief that if we're informed about what we eat and exercise, if it's in front of us, we're likely to pay more attention to it and stay with it. So to that end, I think it would be worth doing it, having it in place for a year or two, tracking it, and then making a decision whether it should continue or not.
One more question.
Mr. Chairman. Am I being recognized?
Go ahead, Susie.
Okay. During your presentation, you did indicate that some people may not be eligible. So is this wellness program open to everyone, or are there some employees that can be excluded from enrolling in the wellness program?
It is not eligible and open to everyone, but I would say probably 98% of people are eligible for the program. The eligibility criteria are, I'm going to try and remember from the top of my head, a type 2 diabetes diagnosis, an obesity diagnosis, on any kind of medication for anxiety, depression, skin issues, sleep issues, gut issues as well. Any of
So
those.
if you don't have any of those and you're currently healthy, you cannot enroll in the wellness program to maintain being healthy?
You cannot enroll in Digby.
Oh,
yes,
okay.
That's correct, because the purpose of Digby is to lower the medical claims to target the employees that are not healthy.
Okay. So there's no incentive for employees who are healthy to remain healthy through the program.
To be healthy is their incentive, yes.
Okay, thank you.
Yes, you're welcome.
I have just a question with human resources. Have any incentives in place right now, even if it's minimal? Or what have you had in the past with other programs that possibly really worked?
Okay, so Juliana Demers, my HR director here for the county. I will let Leanne speak to the past incentives, but like currently what we have been doing, and I just want to clarify that Digby is one component of our wellness program. right? So we brought in earlier this year, a wellness coordinator. So I think like Tori mentioned, Amanda, she was brought in as our communications person for our wellness program. So we did put in place some additional rewards, such as additional classes. So we are holding classes related to like yoga, tai chi, and so those are happening like in the county and like right now only in the Kingman campus, but they are happening with the intent of having employees like being rewarded like through Tori's presentation with on-site classes and efforts. We do have like also presentations of like a healthy coach, health coaches and nutritionists that are speaking. We are working with the health department for a whole nutrition program in addition to the current, like degree program, but one for people that don't necessarily want to enroll and use an app, but they can have like paper format, because what we've been finding too, in a certain way, is that we have a population that is not like an app-driven population. So the non-app driven population, it's not necessarily wanting to engage, but we were thinking that if we show the benefit through this health department nutrition program, and then present them with the app and with this constant, contact with a health coach, might help them to then enroll and engage with DB as well. We do have incentives as far as, some rewards, and it can be coolers, or for water challenges we have like little cups and things that people really like, gym equipment, gym bags, that people can even build their own gym at home or bring to work through engagement with the wellness activities, such as the classes, or engaging with an app. And what we are doing too, in addition to that, is launching this Wellness Wednesdays. So what that is like every Wednesday, we are launching a newsletter just talking about health, mental health, physical health, the nutrition. And so employees receive this engagement letter every Wednesday. And for the employees that don't have access to county mail, we just distribute this in a paper format. And we are trying to push more information through those two. We are actually, with Tori, creating a more robust way to really, engage people into the program, so they can, start engaging with those specific apps such as Digby and Hinge Health.
Okay, we're gonna wrap this up.
Can I ask one more question?
Sure.
So Digby, so $1,050 for each employee that signs up and billed quarterly, but I'm assuming that if they sign up, the county or the trust is going to get billed for that entire.
No.
No?
If they stop engaging with the program, they drop off for claims.
Oh.
Yes.
How soon do they drop?
I believe that it's 60 days. I would have to double check on that though.
Okay, Juliana, can you come up with some ideas next few months? No giant rush on this. Can we please get more people on Digby?
Yeah.
Pay them. Do what you need to do. Okay, get my claims done.
Good.
Let's move to tab 8, I think we're at, which is Gallagher Marketplace. Anything to talk about? John, is that you?
Yeah, that's me. So, in working with staff, they're researching ways to implement additional value-added benefits for their employees. One of the potential solutions is to offer an array of variety benefits, through what we call Gallagher Marketplace. So, as I mentioned earlier in the benefit overview, you already have a couple voluntary benefits, 3 that folks can go out and purchase. The difference here is this allows employees to shop for additional voluntary benefits year-round through a single hub, so it doesn't rely on open enrollment in participation requirements and things like that can jeopardize your renewals with that particular vendor. So this would just be a portal that goes on to the county's website. Employees can go in and look at all of the array of potential things that are out there. Some of the few are auto, home, boat, pet insurance, RV, ID theft, legal plans, things that they may be shopping for on their own or trying to compare prices. This would give them one hub in order to do that on their own. No cost to the county. It's just, again, a kind of a value add in providing an avenue towards additional services that your employees might be interested in. In addition to that, there also is a corporate perks program that also has discounts, say on like Costco memberships or Disneyland passes, and there's hundreds of other ones. But yeah, I think everybody's familiar with certain types of corporate perks programs. They may have avenues to purchase new appliances at a discounted rate. So all kinds of things that would be at the fingertips of your employees, in one spot. So this was just bringing it to your attention that this is an option that's available.
Any questions for John about Gallagher Marketplace? It just seems like a reasonable value add to me. No cost to the county?
No cost to the county.
I'd love to entertain a motion to implement Gallagher Marketplace.
So move.
Okay, you have a second?
Second.
All in favor of the motion, please say aye.
Aye.
The ayes have it. We now move to my second favorite tab of the day. Who would like to handle the discussion about providing gym memberships?
Chairman, a while back, it was brought to my attention by a county employee in the Lake Havasu City area that while we, the county, offer actual physical gym locations in Kingman and Bullhead City, we do not have similar arrangement in Lake Havasu. It was only fair, and I responded to that inquiry and said, I promise I will look into it. I tasked our HR department. My initial thought was we would find a place in Lake Havasu where we can provide similar arrangement. Unfortunately, that physical space is not available, and it would take a lot more resources to provide it. But it's fair that we provide comparable benefits. Our HR department didn't just stop at, well, we don't have a physical location, therefore sorry. They went beyond and looked at alternatives. What I'd like to ask Juliana to present is that alternative and how we can go about it. I believe it's a well thought out proposal. She has worked on it with our finance department. They've checked the market. What you're going to hear, I think, is a reasonable and prudent. It provides for that comparable option without breaking the program, and I'm going to turn it over and let her talk us.
John?
Tell us about it.
Thank you. Yeah, so we went to try to find our physical location and establish a gym like we have to, but it wasn't like really financially feasible to to convert any spaces that we had into a gym. So we came up with a solution that would be trying to find an alternative. It could be like a gym membership, but what I, like through research is that if we were looking for, an equitable way of addressing the situation is that Lake Havasu staff are not the only ones that don't have like a site-owned like gym facility. So we identified those other locations where employees don't have access to a county-owned facility. So in order to just tackle the problem, like on a larger scale and make sure that we address every single employee in locations that they don't have access to gyms, we decided to implement this reimbursement program for gym membership. And this is kind of almost like a reward for people that are already engaged, they already have a gym membership, and an incentive for people that don't, so we can contribute to part of their membership. So the program will function to where the employee location basis is 15 miles away from a county-owned facility. That's when they are going to be eligible for this program. So they will have to present us a receipt that they pay for a yearly membership, or if they do a monthly membership, we just need the receipts up to a certain time of engagement with this gym membership, and then they will be reimbursed. The reimbursement is going to happen like once a year. And right now the program is targeted for a dollar value of $60. And, like we had some, there was a lot of studies on how to come up with the $60 is just like not, it may or may not be the ideal, but as a pilot, that's what we're proposing today. It's based on, first, what we have already available under the wellness budget for the county, because this was not a budget item for this current fiscal year. So this is something that the $60 will be able to be covered if we have, like at least 50% of engagement to this reimbursement program. The number was kind of come out from popular gym memberships, like a gym membership that is available everywhere, costs about $180 a year, and we were thinking about this reimbursement needs to be proportioned to somebody that has access to a gym membership. Obviously, it's going to have access to a lot more equipment, a lot more, perks than somebody that has just the access to the actual county facility, because we have limited resources within our facility. So a third of the reimbursement for this annual membership sound like something comparable, that it's not going to trigger people that have access here to say that they're unfair because now they wanted this reimbursement as well. So we thought that this could create a balance between the availability and the ones that have the gym membership. We are going to propose this as a pilot. This can be reviewed again during the annual meeting if we decided that, there is, people are, really enrolling into this. There is traction. We have enough time to get some feedback as well from staff to, we will see how this is going to balance, and then we can reshape the program if we need for the upcoming fiscal year.
Okay, so when you said in the description, this is a pilot program, you meant in turn, not the geographical coverage being a pilot, but just the idea of the program and then maybe upping or reducing the reimbursement at a later date.
Yes, and I think we are open to everything. It could be that the geographic, we could change the geographic, if that's what we decide. If that's, so we can change the amount and we can change how we're going to do this. I think pilot is just, so it's introducing the concept and introducing just addressing the need, which is making sure that everybody has, equal access to a workout facility at this point, and then we can just do the analysis, within the next 6 months and see how do we want to reshape this pilot program.
Okay, does this have to go to the board?
No, Mr. Chairman, I do not believe so, simply because it is contained within the EBT program.
Good.
So, Mr. Chairman, if you're ready, I would like to have the honor of
One question.
Yeah, so the $60, it's $60 per year or per month per person, or?
For the year, for employees only. So this pilot program is not extending to family members membership. It's just for the county employee membership.
Okay.
I just point out that the way that Juliana and I have discussed this and set it up is that the employee, after the fact, after they pay for their gym membership, they would have to substantiate that with receipts that they give to HR. HR will together list the employees that qualify for the $60, and then they'll send that list of employees to my department to payroll, and that would get issued as part of the next payroll run.
Yeah, it's good to have the receipt, because some of the gym memberships are less. And they'll say, "Oh, I get an extra $60, and the membership's $20." And depending on where you go, and what you do, and stuff like that.
So just real quick question. So when you're talking about, you did have other facilities, locations that you had, like a area for a gym and stuff like that? Is that the way I understood it?
Yes.
That you provided the equipment and things like that?
So we were looking to, so the only option, in the Havasu area to do this was gonna be trying to convert a break room, staff break room, into a gym facility.
Okay.
But the cost to put adequate flooring, ventilation, really equip that, and create doors and access to bathrooms and access to water would be, something that it looks like wasn't at this point in time tangible for us to go that route. And would also not address other employees in locations such as Fort Mohave,
Right.
Fort Dam, Colorado City, because they also would not have an option.
Yeah, thank you.
Mr. Chairman,
Yes.
I saw I did see in the presentation, and maybe this is a question to Luke. This is a taxable benefit. So how do you code that? When it's only $60 a year, but it says here it's taxable.
Yes, Susie.
How do you code that in your?
Any time that we have a cash or a cash benefit or something that is easily convertible into cash, like a gift card or something like that, it's always, regardless of how small the dollar amount, it's always taxable to the employee. That's per the IRS guidelines. And so what essentially happens is that I get a list of employees from HR, and we add $60 to each one of those employees' gross pay for whatever pay period we issue the reimbursements in. And there's tax withholdings on that, just like there are for their salary. And so at the end of the year, their W-2 that they get is going to have an additional $60 that would be designated as a taxable fringe benefit.
Okay, so it's taxable fringe benefit, not an addition to their wages,
Correct.
which are taxable.
It gets added to a paycheck, but it is separate. It's in a separate box on the W-2, and it's coded separately within our system.
Okay.
Okay, Mr. Elders.
I would like to make a motion if you're ready for one.
We are.
I move to approve offering eligible employees a reimbursement in the amount of $60 yearly for out-of-pocket expense for personal gym membership.
I'll second that. Okay, we have a motion and a second. All in favor, say aye.
Aye.
All opposed, say nay. The ayes have it. Very good. Joanna, good job on this. Thank you very much for your hard work on this one. Okay, get a caffeine jolt for the next 3 items. Okay.
I think that's a wound.
This was tough reading.
Yeah.
John, you want to take it away on tab number 10, please? We're going to talk about the incurred but not reported claims reserve.
Sean, I thought it was easy reading.
It is.
Yeah.
It's
Yeah.
Wait till we get to 12.
Yeah.
We take a quick
Yeah.
Oh, you want to take a quick break? 5 minutes?
Sure.
Yeah, let's take 5 minutes. You stretch before you get into IBNR.
Yeah, this one sounds a little intense.
It's not an exercise of diligence. So,
Okay, Susie's back, we can, if we could get, our Gallagher team to. How much time do you need for?
10 minutes, 5 minutes?
Beautiful. Let's go. We want to save a lot of time for tab 12.
Okay, yeah. Oh, good. Yeah. These are formula-driven numbers, so it's an update. So we have Chris Marshall, the actuary. So I'll just kind of introduce what this is. This is your updated incurred but not reported estimate as of 6/30/2025. Every fiscal year end, a new IBNR is presented, and essentially what that means is if you were to stop the plan as of 6/30, what is the liability that comes in after that? I guess the things to note are, there's a pretty good increase in the number this year reported from Chris versus last year, about a 14% increase. I will let him explain the nature of the components that drive that. But ultimately, it went from 2.7 million to almost 3.1 million, about a shade under a $400,000 increase in just the true estimated IBNR. And these numbers, they do include any contractual administrative settlement expenses as well. So with that, I'll turn it over to Chris with anything to add and address any questions.
Chris, take it away.
Thanks. All right. Thank you, Mr. Chairman and John. Yeah, the increase was, there's two factors that drive it. So the first one was the claim lag did change just a little bit, and then they got a little slower. And then the claims payments increased. Your claims for the last 6 months are increased a lot, and that's ultimately what most of the lag is based off of, the most recent claims. So that those two factors together kind of combined for the 14% increase.
So a question. There was a discussion about a credit or something in 2023 that got moved to 24, and I didn't quite understand what that was all about when I was reading this last night. Does that make sense, Chris? It's in yours.
Well, we made some adjustments to the claims if there were large claims and they unduly impacted the IBNR. So if you had a really large claim and it had a 2-month lag, let's say, the model might assume that that's going to happen every 2 months. So of course that's not going to happen, and we would adjust for that. So I think that might be what you're referring to, because we don't really adjust the claims except to do that. So that's most of there was a lot of numbers in the lag triangle report that we get that go into that, where we adjust to make up for those differences. So
okay, so Chris, I'm trying to translate like real world impact to this. Does this represent increased financial risk for the county, the numbers off this report? Is there anything I need to be worried about?
Other than just it's similar to as your medical claims go up, your IBNR is going to go up as well, because it's generally it's going to be a certain percentage of that. So this is just a reflection of rising healthcare costs. So it's not, I mean, it's liability that you already have promised, I guess. And so as John mentioned it's when you go to a provider, that claim payment is not instantly paid the same day and payment is made. There's lag where it takes time for the provider to send it in to get reimbursement. The insurance company will look it over and review, and then sometimes there's some back and forth. So it can take on average a month or two. And for really large claims, it can take longer because those take longer to adjudicate. So this is what you would, so like all those doctor visits and things that happen at the last month of the year. So in June, let's say, a lot of those are going to be paid actually in July, August, and this is kind of a reflection of that. If that, it's kind of a simplistic way to think of it. So it's basically what still hasn't been paid, but is owed to providers for services before the end of the plan year.
And then kind of address on if this should be something that you're worried about. Comparing the increase in your estimated IBNR to comparing it what your current cash balance is, I would say it's nothing to be concerned about. You're very well reserved, and the county's in a very good position to withstand not just this liability, but additional claim fluctuation.
Great, we'll get to that.
Oh, yeah, we will get to that. I didn't want to.
Okay, Susie, you have a question? We can't hear you. Okay, she's muted.
Okay, I'm here. All right. Now, how do we do this in the budget, Luke? You have those, do we encumber them from last year's budget to this year? Or it's just primarily taken from the reserve of this year?
Okay.
So when we put together the FY26 budget, specifically to health claims, I'll just speak to that because that's the biggest piece of it. You know, we looked at where we were projecting the claims to be through the end of fiscal 25 and kind of baked that into what we budgeted for claims in FY26. These are incurred in the previous plan year, but they are reported and come through as an actual claims expense in the current fiscal year. So, but they are accounted for when we look at the overall claims, you know, each March when we're putting together the next year's budget for the trust, that is something that's considered.
So are those amounts included then in the new budget for this year, or it's just a carryover from last year?
So
funds are carried over from last year.
No, the funds are not carried over. Okay. We budgeted for that in the current fiscal year. We basically look at the claims and project where we think they're going to be in concert with, you know, working with Gallagher and come up with a number that we felt was reasonable for the FY26 budget.
Okay. All right. Okay. Thank you.
Other questions? I'll entertain a motion on this item to accept the report.
I'll make a motion to approve the 2024 through 2025 incurred but not reported report as presented.
Motion and second. All in favor say aye.
Aye.
Opposed say nay. The ayes have it. The motion is passed. Let's move to tab 11. Mr. Katz, take it away.
Great. So again, Chris will be able to speak to the details, but essentially this is the second component of the IBNR, excuse me, which is your overall financial reserve recommendation, which is two pieces. One is the IBNR itself, and then the other is additional contingency reserve or claim fluctuation reserve. So the IBNR, again, a little under 3.1 million, about 7.4 for the additional remainder. So the total estimated needed or recommended reserve is about 10.5 million. In that second piece, just to give you an idea, is about 6 months of contribution. So it's a fairly conservative recommendation. Okay. And Chris, anything to add on the total reserve requirement?
I think you did everything quite well. So thank you.
So Luke, any impact on budgets, finances, county level by this number?
I'll talk about it on the next item.
I'm sure you would.
It's definitely, when we built the 26 budget, we get updated reserve recommendations from the actuary each August. And so when we're putting together a budget in February and March, we're operating off of data that we got, and that reserve estimate is a point in time. So when the actuary gives us a number, you know, when they give us this $10.5 million number, that's a point in time. That's June 30th, 2025. Obviously, with whatever claims come in, that number would change if they were to reevaluate it at any other point in time. So it's higher than what we were working with. We were working with a $9.6 million reserve estimate last March when we put together this year's budget. So it's certainly higher. It's $850,000 higher than what we were working with. So that does impact some numbers that I'll talk about in the next item.
Mr. Chairman, would you consider pausing on item 11, going to 12, giving him a chance to go through his numbers, and then maybe taking the two together?
Sure. Are the board members okay with that?
Sure. Yeah.
So be it. Let's, we're gonna put 11 on hold. Let's go to tab 12.
I'm just gonna share my screen here for our remote participants. So the first slide is just a chart of the trust fund's cash balance. At the end of fiscal 25, we're sitting at about $11.2 million. You see the history there. We've gone between basically 10 and 12 million over the past 2 years. So that is, no major changes there. This next slide basically has 3 data sets on it, moving from left to right. I just want to explain quickly, I tried as best I could to label these, but I just want to give a little bit more explanation. So that first set of data points is where we were at when we had the last annual meeting in March of 2025. The blue number, the 12.27 million, was what we were projecting the fund balance to be at the end of FY25. So that was our projection for June 30th of 2025. The orange number below it, the 9.6 million, is what I just referenced a minute ago. That was the reserve estimate that the actuary provided in August of 24. Those are basically the 2 numbers that you'll see a little bit later were key figures in building out our budget for FY26. The middle set of data points is the top number, the 10.67 million, is basically our pre-audit data for where the fund balance was at June 30th, 2025. And so you can see that is about 1.6 million lower than the number that we had at the annual meeting in March. And then below that, the 10.48 million is the number that was just presented in item 11. That is the updated actuary's recommendation for the reserve for June 30th of 2025. And then finally, the third set of data points, and you can see that this is basically between March and the end of the fiscal year, those 2 lines cross, right? They switched positions. And so when I basically threw a trend line on the reserve recommendation and projected that out for another fiscal year, it lands right around 11 million. And so that is saying, looking forward to next August, we expect that the actuary is going to give us a reserve recommendation another $500,000 higher at around 11 million. And obviously there's a lot of things that could change that, but the overall trend has been a positive slope. We see that increasing year over year over year. And then the bottom number, the basically 10 million, is now that we know that our ending fund balance in June 30th was lower than what we expected, and our reserve recommendation is higher. This is where we're projecting the fund balance will be June 30th of 2026. So lower than what we had anticipated when we put together the FY26 budget. And so basically just very high level, what changed since March when the EBT board last met? We basically had a net of $1.6 million decrease in the fund balance versus the estimates that we had in March. That was comprised of an increase of about $500,000 in revenue, and that was because our insurance reimbursements and our interest earnings for the trust came in higher than what we had projected. We also had $2 million more in expenses, primarily due to elevated health insurance claims in the last quarter of fiscal 25. In concert with that, as we just discussed, we had an $850,000 increase in the actuary's recommended reserve. So those three numbers are all impacting us. I just wanted to show very quickly, going back over the last 5 years or so, how our recommended reserve from the actuary has increased over time. So we've gone from about 7.6 million to 10.5 million. And as I said, when I project that out to next year, it's looking like if the trend continues, we'd be at around 11 million. So it's an almost $3 million increase in the actuarial recommended reserve. I'm gonna just focus on the middle set of points on slide 85. We are projecting now, based on these updated numbers, that the fund balance will be at about 10 million at the end of FY26. That's $1.6 million lower than what we budgeted for. It's about $450,000 lower than the latest reserve recommendation we got from the actuary. Again, these numbers fluctuate. That reserve is a point in time. So all I can say is that we're going to continue to monitor these as we move through the year and as we approach March and the annual meeting and when we're putting together a budget. I'll be working with Gallagher to see what makes the most sense. We're also going to be exploring whether we can get some sort of mid-year update from the actuary, to kind of see where we are at that point in time. Is the trend staying consistent? Is it realistic to say that we're going to be at 11 million for a reserve recommendation next summer? Should it be lower? Should it be higher? And how should we bake that into our budget projections?
Mr. Chairman.
Yes, sir.
Echoing what I just heard, which is the fund balance fluctuates, that this is a snapshot in time, that these numbers are projections, and probably lean on the most conservative, because we're assuming that the claims cost is gonna continue to go up and the fund balance will come down. I like the idea of not perhaps pausing on making a decision on the reserve balance as recommended by the actuarials. I really would like to not box ourselves into a number where we then have to struggle to meet it, meaning when we get to deciding what premiums and who pays for what. So the idea of maybe waiting for an update down the road that is based on more data points, that appeals to me for those reasons. It's a struggle every year. I think history shows that we as a board and everyone involved from Gallagher and staff have reflected on the past and has recommended a path that has sustained us. And I would really like to make a decision for us to consider making a decision based on more data point, not less, and maybe not making it at this time. My suggestion.
Is this, so when we had that high fund balance, 12.5 million, whatever it was, that was a component, I think, in our decision on how we set the employee premiums and contributions.
You're absolutely correct, and that's one of the reasons why I, talked with John and said, let's see if it's possible for the actuary to give us some sort of mid-year estimate or at least some sort of way of, some sort of factor that we can use and say, well, here's the claims that we know we have had come in so far, and mathematically just projecting out where we think that reserve needs to be at the end of the year, because we just because of the timing of the county's overall annual budget, the EBT board has to approve a budget before the county's budget gets approved in June. And so we're in a kind of a sticky point there where we're trying to project out a little bit further, but we're working off of data that's already at that point in time almost 9 months stale. So
is this something we need to share with my colleagues on the other board? Is this worthy of an update, or should we wait till we're halfway through the fiscal year?
Mr. Chairman, we can do as you wish. Historically, we have not, just because it's really limited to this trust, and this board has been engaged. At some point down the road, if you would like, we can, but at this point, it's probably.
Okay, so we'll leave it alone with BOS for the moment.
I would also just say that, the last 2 years as the EBT board has met each spring, there was a cash or a fund balance that was higher than where the actuary said that it needed to be. And so a conscious decision was made to kind of, well, not the last 2 years, but over several years, a conscious decision was made to leave rates where they were, to bring that down so that, the fund balance more closely aligned with where the actuary was saying that we needed to be. And then over the last couple of years, we said, well, we don't want to close that gap too quickly. And as we look ahead, we're seeing that gap is going to evaporate. And so we need to increase rates. And so we've done some marginal increases in rates. We split those costs between the trust and the employees. Last year, it was almost dead equal 50-50 split between the employee increase to their premiums versus what the increase was for the trust. It's something that we look at each year, and we make a conscious decision on how are we going to address wherever those two numbers are. As they close and as they have now switched positions, that will affect the decisions that we need to make in March when it comes to rates.
Okay, so we're going to leave item 12 alone. It's going to sit by itself. Back to item 11, should we go ahead and make the motion to accept the reserve calculation?
Mr. Chairman, for me, my recommendation would be, if we absolutely have to do that today, for whatever budgetary reasons, then we can. My preference is to not set that number today and wait if we can, if that is not going to be a problem.
My understanding is that number is not going to change. That number is a point in time as of June 30th, 2025. And so this is
item 11.
Yes, item 11. And so this is basically the actuary
accepting the report.
If the actuary were to recalculate that as of June 30th, 2025, none of that data is going to change 2 months from now for that point in time.
Not materially, no.
Yeah. So there's not really any advantage or disadvantage to accepting what the actuary has provided or not.
We want to leave 12 alone.
Yes.
Yes.
12 is really just an update for where we're at versus where we budgeted.
Okay, do we have a motion on the floor for item 11, or do we want to leave it alone?
We need to approve the recommended financial reserves as presented, and I'll make that motion.
Second.
Okay, this is on item 11. We have a motion and a second to accept the report and the reserve calculation. All those in favor say aye.
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 Opposed? The ayes have it. Motion's approved. We're going to have no motion on item 12. And let's move to item 13, the appointment of a CPA/auditor. John.
Thank you, Mr. Chair, and I believe I will turn this over to Luke.
Okay, so the trust gets audited every year. The trust went out with an RFP and selected Walker and Armstrong. That is the recommendation. They have audited the trust the last several years. They are also the counties, doing the county's annual audit through the Auditor General's office. There's a lot of backup in here with the proposal that they submitted. But our recommendation would be to move forward with it and approve Walker and Armstrong.
Anybody have any questions on these 50-plus pages of backup material?
It was good reading.
No, I didn't read it. I'll take a motion for approval of is it Walker and Associates?
Walker and Armstrong.
Yeah, Walker and Armstrong as our CPA auditors.
I'll second.
Okay, a motion and a second. All in favor, say aye.
Aye.
Say nay. The ayes have it.
Thank you
Let's
for all the
move
work.
to tab 14. The budget. Luke, I assume this is yours.
Hey, this one's me.
Yeah. John, it's yours.
This is
So-
Gallagher's budget.
This is Gallagher's budget, and just a little historical context. The reason that we're revisiting this, even though we do this exercise in March, is there's one component that isn't finalized at that time, and those are the stop loss rates. When we do the budget, we put in a number based on our knowledge of the stop loss market, what we think that renewal is going to come in at. Stop loss, as you know, is, it's a very high threshold. They get as much data as they can before they firm up their offer. And that's we never have that firm renewal when we're doing the budget. So, when we come back this time this year, we obviously have that firm renewal, and then we want to inform you what has changed in that budget. So we put in a pretty conservative renewal number, typically about 20%. We were able to negotiate that renewal down to a little bit below that. So the final renewal came in about $300,000 lower than what we estimated in that budget. So essentially what this is we had what it was and then what it is now based on now that we know everything.
And it's good news.
It is good news. So that just kind of savings, it just kind of gets moved to the general admin item.
Okay, any questions from members of the board? I'll entertain a motion.
I'll make a motion to approve the 2025-26 benefit trust budget as presented.
Yeah, second?
Second.
Okay. Motion and a second. All in favor, say aye.
Aye.
Those opposed? Say nay. The ayes have it. Let's move to, we have item 15, what is it?
15.
Yeah, 15.
Thank
So,
you.
John, go ahead.
Yep, thank you, Mr. Chair. I went over 90% of what this was, and in the last one, this is again just officially confirming to approve the stop loss.
Any questions
Oh.
for John or Sav? John?
Just a quick, I guess, some things that did change was just in the amount of liability that the county takes on. They made a move to increase from $145,000 to $165,000. At that time, looking at the renewal option, we had analysis that predicts the amount of claims, and then it compares it to how much the stop loss company says, well, if you increase your deductible, we're going to reduce your premiums. So based on our models, it said that the additional risk was a benefit to the county because the amount that they were reducing their premiums exceeded that number. So it kind of made it a no-brainer. And then comparing that to obviously your cash position being well reserved, it was a pretty easy decision to say, well, we're in a position to take on more risk, and they're providing us with the savings is greater than that additional risk. So that's essentially what had changed.
Okay. Any questions, Mr. Hats, from board members? I'll entertain a motion on item 15.
Motion to approve the stop loss life renewal as previously found.
And I'll second. Okay, all those in favor say aye.
Aye.
Okay, the ayes have it. Let's move to item 16, which is a telemedicine benefit. John.
Great, Mr. Chair, trustees. So this is an update. So in the past, the federal government through the last 5 years, because of COVID, has allowed telehealth to be covered at no deductible under a high deductible health plan, where prior everything has to be subject to deductible coinsurance, or it jeopardizes the health savings account, its qualified status. So during COVID, they allowed that because people weren't allowed to leave, so it made sense. So then they pulled it out, and then they put it back in and extended it, and then so here today, after the one big beautiful bill came out, part of that bill was to make that change permanent, to allow telehealth to be included at no charge if you wish under a high deductible health plan. So we think that's good news. So since it's been in there and pulled back, we think it's a good move to just put it back in. So our recommendation is to approve the change, allowing participants in the high deductible health plan to receive telehealth at no out-of-pocket costs effective January 1.
Is there any impact on our budget, on cost of the county?
Negligible. Telehealth is a very reasonable price. So yes, any enhancements to benefits is a cost, but it is a negligible cost that, technical term would be a budget dust.
Okay. Questions for Mr. Hats? I'll entertain a motion on item 16. Jeff.
I'll make
Yeah, go ahead.
Approve the plan change of allowing participants in HPHB to receive telehealth with no out-of-pocket costs effective January 1, 2026.
I'll second that. So we have a motion and a second. All in favor say aye. Opposed, say- The ayes have it. Motion approved. Let's move to item 17, risk management plan. John.
Thanks, Mr. Chair, trustees. So every year we put together a risk management plan. It just goes through kind of the annual calendar of things that we're going to do for the county and open it up for discussion if there are any additions or changes to that. A lot of this is consistent year over year. So really the only one I'm going to highlight to talk through is number 3. Again, there's a second year audit. So there's going to be continued prescription drug audits. So as we get those results, those will be presented. And then the prescription drug RFP that we just talked about in an earlier item. As you know, that's a fairly substantial project. So I wanted to make sure that that is listed on here. The rest of the items are just kind of the core scope of services that are larger than just the day-to-day that we want to point out to you all.
Questions for John on this particular plan item?
I do.
Yes.
How do we get the men to participate in some of these programs, number one? And I would suggest, I know at the beginning when people are hired, they're inundated with information. Is it possible to send out, like after employees have been here 3 months, 6 months, a new information to newer employees that say, hey, we have Hinge Health, we have all these other programs available. We were inundated at the beginning, maybe you are ready for that information now. Do we send anything like that out?
Juliana?
Yeah, so we do send those monthly flyers, about with the different programs that we have. We do just implemented 2 months ago the Wednesday wellness where we're packaging all of it. But we are I can always look into some more customized approach to different groups and then target them separately to what we think the needs are gonna be. But definitely we can do this. And I'm thinking, you know, like we can also put together maybe like a quarterly benefit meeting for employees where we can open, you know, like a Q&A session, you know, like maybe on an outdoor, and people can come in and just check questions about their benefits. We do, in addition to this, are holding our health fair on October 30th coming up. We are bringing, you know, a lot of those vendors back in. We will also have remote sessions with them. And we are just launching right now a survey with employees to what do they have, what health-related questions and benefit-related questions that we can address during the health fair as well.
That's a good question. Okay, any other questions on tab 17? We need a motion on this. Right? To accept the plan.
I'll move to approve the 2025-2026 risk management plan as presented, including items discussed today, such as the audit of prescription benefits, as well as the request for proposal for prescription benefits.
Okay, do we have a second?
Second.
Okay, we have a motion and a second. All in favor, say aye. Those opposed, say nay. The ayes have it. Move to item 18, tab 18. John, you're going to give us an update on a whole bunch of stuff.
Yeah, this is a quick one too. This is the administrative update. So appeals claims. So a member appeal occurred that led to a third level appeal. It was approved at that point. So just an update is any claims that were denied to that member have now been reprocessed as paid. So I know that was a long, tough process, but it's good that it's got through conclusion. Every year there's a query fee that's mandated. It was about $5,500, and that was paid in July, so it's already been taken care of. Medicare Part D letters. Each year, Meritain will send out a letter per household to inform members if they are on credible or non-credible coverage for the purposes of Medicare Part D. All the plans through the county are determined to be credible. And then the annual renewal meeting, we're going to begin working with county staff to finalize the dates of the annual conference. So that's really the only updates. Yeah.
Okay, no action required.
Nope.
Item
John.
tab 18.
Just for the first item, when was that paid out? Is that part of the spike that we saw in Q4?
Yes.
It was. You know, how much?
It was close to $1 million.
What'd you say, $1 million?
It's close to $1 million.
That's right, and that was the fourth quarter, is that what spiked it?
And because the third level appeal was successful, the stop loss kick in on that?
You received reimbursements.
Okay.
Yeah, it'd be, yes, so, yeah, the answer is yeah, I don't even want to go down the other path.
I don't think any of us were sad that it was denied. I think we had to make the choice that we made, but our hearts were broken making that decision, but,
For her.
yeah, that was hard.
Yeah, and that's exactly why you have those third-party reviews to keep, from having to make that decision. It goes through, strict medical standards to determine those, but it is never easy.
But how will that fourth quarter spike affect this year? Are we gonna see maybe better numbers because of that spike?
Well, in a sense that we don't think that spike is going to be repetitive.
Right, yeah.
So it is smoothed out a little bit, but it does show up at the time as a large claim. And because of the timing of it, it does show a spike versus maybe if it went through approval right off the bat, based on the claims falling, it would have been amortized over a longer period of time versus being backlogged and then paid, in a shorter time period. That really shows the spike. But from a budgetary standpoint, in underwriting, that is taken into account that if there is any ongoing nature and cost, we factor that in. But if there's a change in severity that shows that it's not going to be repetitive at that same level, we do remove that amount and not assume that the county's going to have that same liability year over year.
Okay, and can I just follow up with a question I asked very early in the meeting about the formulary? Because the particular case that we're talking about, there was a cheaper medication that the doctor recommended that was included in the formulary, but, let's see, or just the opposite. Anyhow, he could have had something that was not on the formulary that was cheaper, but instead we have $1 million bill because of this medication that he was taking. How does somebody know to go about that process a lot sooner in this process? And I know that was kind of messed up deal, you know.
It was a unique circumstance that I don't think that is something that's reflective of majority of your members' experiences as they're filling prescriptions. But, when it does get to a level like that, some of the resources that the county has to guide the member through that would be through case management that allow them to help them explore options, reaching out to physicians and helping them guide would be a resource that would help the member. If they don't engage in those resources, that's when a member can be at a disadvantage of knowing what's available to them.
But there's no way to change the formulary for an individual case like that one.
There are exceptions that you can expand the formulary. And again, expanding a formulary could result in higher costs. What the PBM does when they manage the formulary, they're looking at millions of drugs, say, for example, and then they take out of that a subset that is going to be hopefully the highest quality and the lowest cost. And then each drug on there should have backups as far as clinical efficacy. So every now and again, you do get instances where somebody may have tried a drug that was on the formulary previously and it didn't work for them. It did, they had side effects and they had to reach out for an exception to get something that's not on the formulary. So there is that process as well, to where if it's determined that an exception can be made, that individual can take that drug without having to add that to the whole formulary because they've gone through the exception process.
Thank you, sir.
Okay, let's move.
Mr. Chairman.
Yeah, Susie.
Yeah, Mr. Chairman, I would like to ask, in line with this appeal process, the resolution of this, are there any things that we're doing differently in the process as part of this case? I think if I remember right, it has something to do with a pre-authorization issue at one point in time. Now, are we changing any process so this one does not happen again?
No, there has not been any change in the procedure. I think as frustrating and challenging as it was, it went through the process that's in place. There is, just a background. It got denied due to medical necessity. So as the team, it was determined that there were other avenues, that this certain avenue was not medically necessary. Through the appeals process, it ultimately ended up the third time you're being deemed medically necessary and therefore getting approved. Unfortunately, that's the process, and that is, again, not a county process. That's a process within the third-party administrator that you partner with, and it's a hands-off process to the county because you want it to be. You don't want to be on a medical claims committee. You want the third-party folks that's their job, is to review these claims and determine medical necessity. Unfortunately, every now and again, the process doesn't work as smoothly as we'd like the member to have to go through. But as a result of this, Susie, to answer your question, no, there's not been any change in process or procedure.
Did you have something, Sam?
Yes. In light of that claim, in understanding and sizing the impact of the claim on these numbers in the future. And looking back to item 10 that talks about the IBNR. Um, 2 months, and I don't know when this claim was paid, but 2 months. April of 25, which was paid in May, and then May 25, which was paid in June. We had numbers that I had not seen before in 5 years of it, which is in excess of 600 in, excuse me, in May and over 850 in June. Is that when that claim was paid and processed? And if so, how do we recognize that that's when this one unique and rare claim was processed and it's not going to impact our numbers as we project that?
Do you know when that was paid? So to answer the second part of your question, well, we kind of researched when it was paid. When Chris was going through the IBNR a little bit earlier, he did mention one of the few discretionary adjustments that he does make is to abnormal large claims when they show up, and he does smooth those out. So a portion of that claim obviously would be included in the calculation, but to take 100% of that at that point in time, he does smooth that out.
Okay, I won't dwell on it other than when I hear our chief financial officer saying, well, our costs increased by $2 million last year. In my mind, I'm saying, well, gosh, if the claim was $500,000 or $600,000, that cost increase now, in my mind, is $1.5 million, not $2 million. And so I'm just trying to reconcile that.
I just wanted to say one other thing in response to Susie's question. If I recall correctly, the issue with that appeal was that the doctor wanted to prescribe a medication for an off-label use, but when they contacted the plan to get the pre-authorization, they didn't bother to mention that it was an off-label use of the prescription. And that was part of the issue, which led to the ultimate denial of it.
Wasn't the prescription approved just not for what that patient needed it for?
Yeah, that's
because it was an off-label use.
Yeah.
Okay, do we have a date paid?
So it looks like the claims came through around February and March.
Okay. Okay, let's move to request for future action. Any board members have requests for future action? So at our annual meeting, I had casually brought up something that interests me is incentivizing members of the plan to voluntarily leave the plan if they have alternative sources of coverage available to them. That is something I would like us to look at, to reduce the number of people we have in the plan. It's one way to reduce claims. So am I out on really strange territory or what?
No, it is something that you can certainly research and kind of get the pros and cons of the ways of doing that. There's waiver credits, which have a cost, but typically it's lower than the cost of somebody on your plan. So we can just research kind of all the avenues of.
Okay, when is our next board meeting?
March.
Yeah, March.
Okay, that's a ways off. Okay, but could we have something ready for the March meeting?
Yes, absolutely.
We could talk about it. Juliana?
And so just like in anticipation to, like the request in our conversation prior to this, we did start this cash in lieu program, like evaluation. So we do have, like some already, like some basis, and we will be sharing with Gallagher and working together with finance for that as well.
Yeah, maybe you can move us something prior to the March meeting.
Yes.
We don't need to have a meeting to discuss it, but I mean, you can put out an information packet.
We can also have a special.
I can't understand you.
We can have a special meeting for that if you'd like to.
Okay, well, let's see what the material looks like. If we want, we can have a Zoom meeting, cover it. Okay, any other items for the good of the board, anything? We're gonna go ahead and adjourn the meeting. Thank you, everybody who participated. Good job from staff.
See you in the next meeting.
Susie.
It's a lot of work.
I hope to see you in the next meeting.
Thank you, John. A lot of work. Thank you.
I told you I didn't have meetings.